everybody. This is a joint presentation with the McIntosh Library and Vernon County Over 50. We have Dr. Troy McKay here today, who's going to talk to us about macular degeneration, which could happen to any of us.
Round of applause. Here we are to Dr. McKay.
Thank you. I see some familiar faces in the crowd there. So, yeah, I'm one of three optometrists here at the Gunderson Eye Clinic, along with Dr. Nahas and Dr. Williamson. And then we also have a ophthalmologist, Dr. Whitford, that rotates down to Baroka for cataract surgeries and other medical stuff. So, when I go to lectures, they always talk about financial disclosures. I don't own stock or any money in any of the products that I'll be promoting, or this is mostly educational. This is not to sell you anything, just educational. So yeah, we're here to talk about macular degeneration. It used to be we couldn't call it age-related macular degeneration for abbreviation. We're just going to call it AMD. It's the leading cause of severe blindness in adults over the age of 50. Approximately 20 million people in the US have it, and 1.5 have the advanced form of the disease, and we'll talk about what the advanced form is. There's about 200,000 cases of wet AMD each year in North America. So it's very prevalent, and I'm sure if you're not affected by yourself, your friends, neighbors, almost someone knows somebody, just about everybody knows somebody that may be affected by this condition or disease. So, and it's only going to get worse. So it's expected to go from 2.1 to 5.4 million people by 2050. So doubling in the next 30 years. So first we need a basic anatomy lesson on what is the macula. So the front of the eye, like if you wear contacts, that's the cornea. Then you have the colored part of your eye, the iris. And then the black center is your pupil. That's just the opening into the eye. And then you get to the back of the eye, and then we have the retina. Now the retina is like, if you remember the old-fashioned cameras that had film, the retina is basically the film of the eye. That's where the picture gets developed. Now in that area, there's a sweet spot, like a bullseye. And that's called the macula. The reason that's special is because there's no blood vessels right in there. Blood vessels would actually limit how well of detail we could see. In fact, if you get outside the macular area, most of our vision is about 2200. Our peripheral vision is meant to pick up motion or no motion. It's part of our basic rudimentary defensive skills. Am I seeing it, not seeing it? It's not meant to pick up details. Our straight ahead vision is what gives us our details because it has more concentration of cones. And so that's what provides the details. And that's the area that wears out in macular degeneration. So again, think of it as the bullseye of the back of your eye. So what we see in there, so that was more of a diagram, but inside the eye, again, when we look in there with the microscope or any of our instruments, we see this big yellow disc. That's your optic nerve. That's the part that connects your eye to your brain. And then we do have blood vessels that supply blood flow to the eyeball. But again, right in the center here, this big area is the macula. And then there's even a bullseye within the bullseye called the fovea. And that has the most concentrated area, and actually even has a special shape to it to give us super clear vision. So now, most of you may have heard that there's two types of macular degeneration. We call one the dry. And again, this is all clinical for what we describe. It doesn't affect, because you may have been told you have dry eyes, or maybe you have watery eyes that's on the outside of your eye. So this doesn't have anything to do with having dry eyes or teary eyes, watery eyes. That's a different talk for a different time if we want to have you back for dry eyes. So this is all inside the eye, what we see. And this is the early form of what most people have, is mild, dry macular degeneration. Most of us have gone back to the term non-exudative, meaning we don't see blood or fluid, which we'll get to shortly. So what we see in there is these little deposits called drusen. And drusen is basically if we think of our cells as recycling machines, they're always firing and working, but that has to reset itself. If you've ever been flashed with a bright light, you see the after image for a while. That after image is what's taking your rods and your cones to reset. So your cells are always taking in energy and getting rid of the metabolic waste. Drusen is a buildup of that metabolic waste. So our cells kind of get not so good at recycling themselves anymore. And that can continue to build and build. So that's the dry type. Dry type has drusen. Things are starting to wear out a little. Now, wet macular degeneration, this is again all from the inside of the eye. We also call it exudative or neovascular. So if you've heard any of those terms, they're all the same thing. It's a lot less, but it can be much more severe. It results in 90% of the legal blindness. And it can severely, rapidly take your vision. That's why we're so concerned about it. And that's where we get blood vessels starting to grow in. We'll have some pictures there and we'll show you what that looks like. So again, dry is things just wearing out, like other parts of our body wear out as we have more birthdays. And then wet is where we get blood vessels starting to grow up into the bottom, into the macular area. And again, nothing to do with if your eyes are watering on the outside, or if you have dry eyes, we say use some drops, lubricate. This is all inside your eye. So here are some examples here of that drusen. So again, if we looked at the back of the eye at the very beginning there, let's see if I can show that first picture. You can see here, this is pretty uniform in color. Nice orangish yellow and orange and red. And then if we go on to these next ones, you can see, we see these yellow deposits. That's what the drusen are. And you can see a lot more developing. And then eventually, because it gets so much of that buildup, it starts to break down the layers next to it. So at the cellular level, you're seeing this is the normal rods and cones, and we have the blood vessels underneath. And then what happens is we get this little buildup of yellow stuff underneath. That's the metabolic waste where our cells are trying to recycle themselves. And then we get a little more of that stuff. And then it starts pushing out the other cells, the basically the bottom layer. And then it just wears out. It destroys the neighboring cells from that buildup of metabolic waste. And so we'll talk into why that happens and some factors for it. So again, this is dry macular degeneration. You get drusen, more drusen, and then basically cellular death. Now, this is what wet macular degeneration. You have a lot of blood, and then basically there's a bottom layer to that retina. Because there's no blood vessels in the macula, it gets its nutrients and blood flow and oxygen and nutrients from the layer beneath it. And what happens is there's a dam there. It's called Brooks membrane. And the dam starts to wear out. And then the blood and the fluid from underneath leak up and make the middle part of our macula wet, where we get blood and fluid where we don't want it, right in our bullseye. So, and it can happen at any stage. Just because you have mild dry macular degeneration, it can still switch to wet at any point. There's dry type will go in order, like dry, you have mild, moderate, or severe. But at any point of those, it can switch to you on wet. And that's why we keep watching you, say, come in for regular checkups. That's why you all have an Amsler grid, and we'll talk more about that in a little bit. So this is, again, where we get blood vessels growing from the layer underneath. We really can't see the choroid layer, but underneath this next layer of retina is another layer that supplies blood and oxygen and nutrients to that area where there is no blood vessels. So again, at the cellular level, what happens is you get blood vessels. So here's that dam. And again, this area doesn't get nutrients from the normal blood vessels that you saw before. It gets it from underneath, but this weakens from that, from those cells changes, and basically the dam breaks loose and we get blood and fluid and even blood vessels growing into where we don't want them. And that's considered the wet. You could also say the words exudative or neovascular. So that's the kind of the difference between the wet and the dry. So dry, things wear out. Wet, we get blood and fluid right in our bullseye. So what this can do is it can give you all these kind of distortions. Again, if it's early or mild, you might not even know you have it. Even intermediate, you might not know it have it. We can start seeing it at the mild. And certainly at the intermediate and advanced stages when we look inside the eyes. And then late, you can things start to get distorted. You might have a black spot in your vision, just blurriness overall. And images just not as sharp and crisp. Again, the macula is your bullseye. That's where you get your distinct sharp vision. You can be looking at something, you will still have your peripheral, but the details of somebody's face might be missing. So we passed out some Macular grids. This is the best take home thing ever. You can just take it. And the biggest thing to remember when using the Macular grid is cover each eye. Both eyes working together, you might miss some areas. So cover your right, cover your left. You look at the center dot. If any of those lines get wavy, distorted, funny looking, so you get distortions, spots missing. So I had a patient, I think it was today or yesterday, she didn't even see the black dot. She goes, so this whole area was gone, kind of like this, but it was right in her center. So again, you can have black spots or just spots of the grid missing, distorted in multiple different ways. So stick this on the fridge, stick it on the cupboard a couple times a week, cover it. I have one lady, I said, well, do you have an Macular grid? She goes, no, I use my blinds. If they start getting wavy or crooked, it's fine. So any really straight up, people use their calendars, curtains, anything that should be straight and it suddenly isn't. I've had people say their door frame suddenly got a bow in it and their door was straight. They look, I closed one eye, the door's straight. I closed this eye, it's got a big bow in it. So straight edges, straight lines, they start to get wavy, distorted. Let your doctors know. Preferably your eye doctors, but your medical doctor's fine, but they're gonna send you to us anyway, so. Yeah,
Does it always mean macular degeneration if you have something like that?
good question. Question, does it always mean you have macular degeneration if you have something like this? It does not. In this case, it can be other things, but in general, if you have any of this, it's usually make sure you have it checked. Or if you know you have it, then we watch to make sure it doesn't get bigger. So the lady that was just in recently, I had her circle the area and put a date on it. Okay, this is your new baseline. Here's what we've already have some damage. Now we're gonna see if the damage gets bigger or worse. So we can circle and date it, but no, there are other macular disorders, macular issues, or other retina issues that can cause these distortions. So it is a good just self-test of any eye function to make sure your eyes are functioning properly. All right, so how do we test for it? So we certainly can just look in there and like you said, we can see normal retina or we start to see this yellow stuff in there. But we also have some amazing equipment, some cameras, some scanners. And you can even see at the cellular layer cross sections of the retina. I mean, the retina is only microns thick. We're talking thousands of a millimeter. And then it can break those down into layers. Those drusen we were talking about, we can even see those on the cross section, these little lumpy bumps, if you can see that on the screen. I'll also have some more pictures of those here shortly. So make sure you come in for regular eye exams. That's kind of the easy one.
So you look for that every time you see us users at your.
Yes, so we always will look for, I mean, we always check you for cataracts, glaucoma, macular degeneration. Now, I might not always do this scan on you. That's not kind of standard of care for just a regular eye exam. But if we start seeing these yellow bumps and lumps or your vision's down, you bet, then we'll want to get one of these scans on you. So, but we're always checking for it because it is so prevalent. It's what everybody fears. I mean, one of the people's I hate confirming people's greatest fears, like they might have macular degeneration or something's wrong with their eyes or vision. A lot of times I think it's.
Is there a treatment for it?
Oh, we're getting there. We're getting there. Question was, do we have treatments for it? And I'm like, some. So yes, this one's called an OCT scan. It's like a CT scan of their body, but we don't have to use radiation. The nice thing about eyes is we use light, and we can use light to see the different sections. So no radiation in eye stuff generally. This is another one we call autofluorescence, and it can start to show that damage. This is literally what you will see on the pictures on when you have the dry type of macular degeneration, and that hole kind of fits with what you see on the Amsler grid. And so we can see it's almost like a small smoldering fire that keeps growing and growing and growing. So again, those scans, we can see these different layers. You don't have to worry about all the layers. But remember I said there's like a bullseye within the bullseye? That's called the fovea. This is your really good sweet spot. And if that starts to get distorted, you're definitely gonna start to have vision changes. And again, yes, there can be lots of other things that can distort your fovea. But today we're gonna be talking about macular degeneration. But this machine, this OCT has been out, 25, 30 years now. And it just changes how we can see things, diagnose things. Before we had to use some clinical judgment and some photos, and you can do this, but just have a cellular cross section of the back of your eye is amazing for us. And so we can start to see these changes. Kind of a normal, this normal dip, again, your fovea, that's supposed to be there with that little one there. That's normal retina structure. You can see some very slight little lumpy bumps on that layer down there, hopefully. If anybody wants to come up and look at these closer, you certainly can come on up in front of the screen more. Now you can see it's starting to look like a cobblestone street up there, okay? A lot more drusen. This one, unfortunately, now if you notice, we have this is some blood down here. It's at the chorial layer. And now you can see right here where there's almost light transmitting through. That means the cells up here have died. And so this transmission is what we call atrophy. The cells are no longer being absorbed to reflect that light. It's passing through, so we call that hypertransmission. It's the classic sign of what we call geographic atrophy, end stage dry macular degeneration. And I'm reasoning by that because it goes back to someone else's question, do we have a treatment for that? And for up to hundreds of years, up until last year, the answer was no, we did not have a treatment for that. Well, we had something that might help a little bit, but this has just changed in the last year. Here we can see again, more blood and fluid leaking up through that area. Again, you're not supposed to have that big hump of stuff in there, blood, fluid. And again, you can even see fluid right in these layers. So you're supposed to see a nice little divot. You start to get lumps and bumps in those cross sections. That's what helps us decide, is this something we can watch or does it need treatment? And these are the wet type. So we got mild, moderate, severe, then wet and wet again. So again, just more examples of drusen. Again, top is the way it's supposed to be. We're getting some lumpy bumps in the middle, and then lots of lumpy bumps as we get across there. And then towards the end stage, we'll see these big areas of cellular loss. That's geographic atrophy. Again, end stage. Usually by this point, the vision is pretty bad, 2200. And up until now, we really didn't have much for this. Here's an image again of the fluid. This is the wet type again. So you can see fluid leaking up into the layers where we don't want it. And again, regular photos, what we see in the back, we'll see blood and fluid in the lower layers of the retina. Basically, you don't see good through blood. Everything in the eye where we want to see is supposed to be clear. Clear fluid, clear stuff. Blood kind of mucks things up. All right, so who's going to get macular degeneration? So we have lots of different factors that can affect it. Smoking is probably one of the biggest ones we have. So if you ever needed motivation to quit smoking, this is the biggest one, I think. We know sunlight and UV exposure can be a contributory factor. Age, we call it age-related macular degeneration, and there are some exceptions to that, but in general, it's age related. Certainly family history. High blood pressure, and again, it goes back to, we'll explain why that's a factor as well shortly. And then maybe you've heard about vitamins. We're gonna talk more about vitamins here in a little bit, but diet is also certainly a factor. All right, so maybe some of you have heard about the genetic testing for macular degeneration. Now you can go, there's 23andMe. You can get tested to see if you're at risk for macular degeneration if you carry, usually it's been 2. There's like possibly over 30 different genes associated with the risk of developing macular degeneration. But it's really been kind of focused down to 2. This chromosome 1 in the complement cascade, and then the ARMS and the HTRA genes on chromosome 10. So you can get these tests and see if you have one or both of these, and that means you could be at more risk for developing macular degeneration. Again, it does not mean that you will definitely develop AMD. Right now, we're just saying there's an association. And that there could be a higher risk for you. So what do we provide, or what do we recommend? And this is through the American Academy of Ophthalmology, that we don't have to test for this. And I'll explain why in a little bit. Let me show you that. And basically it's not going to change what we do. At this point, we don't have enough genetic testing to say, if you tell me you have these genes, I'm just going to stress more of those things. Don't smoke, don't drink, don't. Anything that's good for your heart is generally good for your macula, all right? So, and same with the retina specialists, they kind of said the same thing. Again, the genes, by having that genetic stuff, if you were younger and want to know that, if it helps you change some of your behaviors, that would be nice to know for some people. But again, it doesn't necessarily, if you tell me you have the gene and I've already seen you have macular degeneration, we're going to probably do the same thing we normally would. So right now, the genetic testing isn't changing how we treat you, how we use other factors for that. So it's nice for some people to want to know it, but it's not right now. Until we see that gene targeting tells us we should treat you with this medicine or that medicine or this, that would be more beneficial to us. So if we know your genetic type, then we know maybe this medicine works better for that genetic type. We're not there yet. So, and so I don't recommend testing, or if people bring in their testing, it's like, it's great knowledge. It's good to know, but it doesn't really change how we're going to monitor you, watch for you, or change what we do. So what do we recommend? So you probably heard about vitamins, eating your fruits and vegetables, your dark berries. Like I said, anything that's good for your heart is usually good for your macula. The macula is a high metabolic area. It has to recycle all day long. And during the day, I mean, it gets a little chance to recharge at night when we sleep, where our heart doesn't. But the macula has a higher metabolic rate when it's on all day long. So it has constantly have to be recycling its energy. And so we've heard about antioxidants, and that's the premise of vitamins. You know, oxidation is the same as rust. If metal oxidizes, you get rust. So if the body gets oxidation, we get these things called free radicals, and those can be, stress and toxins, chemicals, radiation. But antioxidants are supposed to neutralize those. At a chemistry level, they will help reduce free radicals, reduce oxidation, get less rust in your body, less rust in your eyes. And so that's where we're currently at. Again, trying to minimize the buildup of that drusen, this buildup of oxidation. This is basically, drusen is the rust of your macula. So we want to help reduce the risk, or at least minimize the production of it. And that's what, at this point, our goal is to try to minimize the production. It is hard to undo that. So once, especially you get to a critical level, it's hard to hold it back. So the biggest study was about 20 years ago, 25 years ago. you've heard of these ARIDS vitamins and then ARIDS 2 vitamins. That they were shown to take intermediate, people that took the vitamins that had intermediate drusen didn't seem to progress to advance as much in 1 out of 4 people. So that means 3 out of 4 people taking the vitamins are wasting their time and money. But at the time, and still today, this is one of the best we have. So they do not, we cannot say that it prevents it. So people are like, well, can I take the vitamins and I won't get AMD? You can't say that. If you want to take the vitamins because grandma got it, mom got it, dad got it, and you want to take them, that's certainly your choice. But I can't say by taking them, you're going to minimize, you might minimize, but I can't say you will prevent you from getting macular degeneration. They don't affect cataracts. That was one of the study results. Fish oil has been heard, everything to cure anything from Alzheimer's, lipids, high cholesterol. A lot of that has been redacted and not so much. The one that I will say is actual dry eyes, when you have watery and dry eyes, that may be one exception that where fish oil might help, but it doesn't affect macular degeneration. And the original ARIDS formula had a whole bunch of vitamin A, beta carotene. Well, we found out that those that had a history of smoking, were smoked, history of smoking, and actually increased their risk for lung cancer. So if we directly recommend the ARIDS 2 vitamins, and that's pretty much the standard care now, just because nobody really needs that extra vitamin A. There's enough carotenoids and vitamins in the preservation to take care of that, and they got rid of the vitamin A. So the original one had a lot of vitamin A. Then now we got rid of that vitamin A, and we have vitamin C, E, copper, zinc, lutein, and zeaxanthin. And you may have heard about these. These are one of the carotenoids that specifically for the eye, for the macular area, that we think really helps with that oxidation. And antioxidation, I should say. Another one is called MacuHealth. This has an extra carotenoid in it, so you also have the lutein, the zeaxanthin, and this other one called mesozeaxanthin. This one has been only out for a few years, and I got to meet one of the PhD researchers on this. Is a wonderful Irishman that did a lot of research on this, and just fascinating to hear him talk about the science of it. And this looks really promising. I would recommend this to either one. Now this MacuHealth alone only has the carotenoids in it. And then if you want the MacuHealth, which was like the ARIDS one, it has all the extra stuff, the C, the E, the zinc, and copper. So, but some people just want extra carotenoids. So they gave that choice. The one thing that was interesting in Europe is how they do their studies, because this Irishman went to the European Union and said, I have this premise on what I want to research on macular degeneration, these carotenoids, and specifically this mesozeaxanthin. And so, yep, we'll help fund your study. And in Europe, they're not allowed to go and make anything from their research. The European Union owns the research. So he can publish it, he can do it, but because they paid him for the research, he cannot come in and say, well, from my research, I want to make it now a vitamin and sell that to everybody. He's not allowed to do that. Somebody else can read his research and go, huh, that's interesting. I think I'd like to make a vitamin from that. So he has no stock, just like I said at the beginning, no financial discourse. He's got no financial interest in this. He's a scientist, he's a researcher, he wants to help people save their eyes and vision. Somebody else, a businessman, came in and said, hey, I like what I'm seeing here. Why don't we make something from it? So when he gave his talk, we were all fascinated. What is this stuff? Where do we get this stuff? He couldn't tell us at all. He went through the whole presentation, never mentioned these things because he wasn't allowed to. So then at the end, we're all we got like, okay, we all looked it up ourselves, like Googled these ingredients, and then we found it. So I like the way their research is very non-biased versus others that, well, I'll bring it up here shortly. I Promise was another one that's done a lot of stuff with vitamins. Their first one was called the DIVUS study, and it actually looked at patients with diabetes and how they lose nutrients and they could benefit from vitamins. But then they came out with their own version as well. They went without the zinc in theirs because there was sort of a controversy with zinc. You know, ARIDS had a lot of zinc in it. And then there was a genetic company that said, well, some people with a certain gene, if you have zinc, that actually might make it worse. So then they said, well, maybe we should have some people have zinc and some people shouldn't. You should get this genetic test to see if you should have the formula with zinc or without zinc. Well, no one else was able to reproduce that except for the people that sold the genetic testing. So good for them. So now it's kind of been debunked. But they continued to do the ARID study. And at the last update, that you really don't need 80 milligrams, because a lot of zinc can be bad for other issues and other problems. And Dr. John, the Irishman, was telling us about some of the components of zinc and how too much may be bad in certain ways, irritate your stomach, some just nothing dangerously bad, but just maybe uncomfortable, some upset stomachs and just not feel good in general. But they show that you just need 25 milligrams. We don't need 80. So a lot of it now has, the newer formulas will have 25 milligrams of zinc. You don't have to have the 80. If you're wondering, like, what else is good for your eyes? Bilberries, you've heard of that. And you name it. I get patients coming in, bringing me vitamins. Like, is this good for my eyes? Is this one good? Ocuvite. Again, the ARIDS 2 is the kind of the gold standard. Everything is compared to the ARIDS 2 vitamin. So if you're not sure, check the ARIDS 2. If you're wondering about, like I said, bilberry, what other things do I hear people bring in? Tea tree oil, or, any homeopathic, natural. I mean, we live in Baroque, so I know I get all this stuff here. So if you're wondering, like, where do I go and find, when in doubt, I go to the Linus Pauling Institute. It's out of Oregon State. And this is what they do. They sort out nutrient information, analyticals. And in fact, when I pulled it up today, it's like, oh, look, they're talking about micronutrients today too. So it's a great resource to sort through the wheat, through the chaff. Is somebody recommending something because they have something to sell you, or is the science legit? And I really trust that site and their research. They kind of filter through, like you said, is someone trying to sell you something?
Is that specifically for eyes or is that in general?
In general. So any nutrient, if you want to know if vitamin C has been touted to help everything, right? Vitamin C is good for this, then it's not good for that. Maybe it is good, and now it's not good. That helps me sort it out. So like I said, vitamin C, I think right now, we don't think helps with cataracts at all. So again, things change with studies changes. So again, if you're looking for more of the most updated research on any nutrient and on whether or not this product really does what people are claiming it does, joint stuff, there's all sorts of things out there that you can look up. But that's just my own personal, like I said, where do I go to find out if somebody asks, well, I take this and I heard it's good for that. No, let's look it up. All right, so back to your question, the treatment. Last year, 2 new medicines came out for the dry type of macular degeneration. For years and years now, we've had stuff for the wet. And maybe some of you all know people or friends that go for injections for the wet. You have to go every month, every 6 to 8 weeks, maybe if they're lucky, every 12 weeks. Now, this one came out last year, and it's specifically for the dry. Now, they kind of sprung it on us without just saying, here, let's let the news people tell, hey, there's a treatment for dry macular degeneration. We're all like, what? What do you mean? So they didn't give us a lot of the homework ahead of time. Because what I want to tell you, it doesn't reverse the process. It doesn't cure it. If you have advanced dry macular degeneration, this will not undo what's been done. What it is if you're in that early stage, can we keep you in the early stage from not getting advanced or moderate to advanced? So the key is, again, getting you on early so that we don't see the spread across, like if we go from that, like we can get you here and keep you from there longer. Can we spread it out? So again, unfortunately, it's not an eye drop, it's not a pill, it's an injection into the eye. So it did show that it could help the development of geographic atrophy, the worsening of dry macular degeneration by 14 to 20%. Neither showed it could restore any eyesight or vision. And I think that's where they kind of their stuff, like, we have treatment for dry. People with bad macular degeneration advanced thought, hey, there's something that's gonna help me, and that's not the case. So if we catch you early, we may be able to help you. But those who have severe vision loss from dry, unfortunately, we still don't have like stem cell transplant stuff.
Dr. McKay,
Mhm.
what were you using 2 years prior to that? And so for moderate or early, you have, you could recommend?
We said the vitamins. Yeah, all the preventative stuff. Don't smoke, wear your sunglasses, try the vitamins. So again, the question was, what did we do before these injections? And it was just controlling risk factors. Control them the best you could. And that was really all we had. Yeah, we didn't have much. So we were pretty excited about this. And then a couple of reports came out that it can actually increase your risk for getting wet macular degeneration by 7 to 12%. So there's about a 10% risk that you might not now have dry, but we now switched you to wet. And now you still get wet macular degeneration injections. So you're getting injections before, you just keep getting them, and they're just gonna switch drugs on you. So that was a little concerning. And then the bigger concern was this report of vasculitis. Vasculitis is where you get a severe inflammation inside your eye. Now, I just went to a conference Thursday and Friday, and they think they might have figured out why this was. It may have something to do with the injectors, the injecting themselves, so maybe this will get better. But this scared a lot of retina specialists off from jumping on this and say, yeah, let's get going. Everybody's like, well, just hold on. You tell me I can give them wet macular degeneration, I might cause a severe inflammation in their eyes. You know, if they're doing okay, because again, remember, we're gonna start treating the early people who might not have any problems yet. And now we might give them problems. So this is why this isn't taking off like wildfire yet. I think we're getting there. Generally, especially in the small town, the Midwest, we're gonna let the New Yorkers and the LA people try it first, and then we'll see. I'll wait a little bit. And you know, at $2,100 a pop every month. And that's just the medicine fee, let alone the doctor fee, the surgery fee, or the injection fee.
Is that covered by Medicaid?
As of right now, it looks like it's going to be yes.
Wow.
Or do you get those injections here, or do we need to go to lacrosse? How does that happen?
They would be in lacrosse. So the question again was, where can we get these injections? Lacrosse, if we can talk our retina specialist into doing it. Right now, he's waiting. He wants a little more research, a little more. So I've been sending some patients that I think might be the right candidates for early. He's doing his own study. So he's gonna kind of enroll and do his, he's got 1 or 2 studies going with Gunderson with the National Institute of Health. And he's gonna kind of do his own thing because he's a researcher, PhD, I don't know if he's MD and PhD, but he's done a lot of research in the past. Our retina specialist, Dr. Shaw is his name. And he's just proceeding cautiously. The last patient, I think he enrolled in the study. Again, a lot of my patients that were severe, I tell them it's not appropriate for you. People that are in early stages, that's appropriate. They hear these risks and they're like, well, I'm not having any problems. Why would I put myself through that potential risk if I'm not having issues yet? So I think we need to, I don't want to say sell it better, but I think we have to prove that it's a little safer. Because we want to target the people that are in early stages who aren't having problems. And there's a chance we could give you a problem. So the risk benefit isn't quite where we'd like it yet. The second one, Izervay, again, Sephora was the first, Izervay was the second. This seemed a little better, less risk for vasculitis, still a little bit risk of conversion to wet. Normally conversion to wet is about 1%. So it's still low percentage wise, but it's still higher risk than we'd like.
Dr. McKay, were those 2 different companies that made those 2 different?
Yes, yep.
In the US or European companies?
I'd have to look it back again at that. I know they got approved in the US last year, so I'd have to go back and see. Again, the question was, are they made here in the US? They got approved by the FDA last year. I'll admit, I haven't gone back and looked at I read up a little bit on it, but I don't remember that particular detail. All right. So again. Switching back to the wet type. Again, it's still. Kind of a wearing out of that layer at the bottom of the retina. Again, stress, oxidation. Brooks membrane is that membrane that's kind of like the dam that holds the blood and fluid back from underneath. And again, it kind of wears out. And that stress, that oxidation releases the stuff called vascular endothelial growth factor, what we call VEGF. And that's what causes the blood vessels to grow and form and leak into the macula. And the reason that's important is because we do have medicines now, and this is what maybe your friends, neighbors, relatives have been getting, or what they call anti-VEGF medicines. These are ones that people have been getting monthly. Some people can go every 8 weeks, every 12 weeks. But these grab that molecule and they can actually reverse some of the changes of macular degeneration. This, I would say, is more of a treatment. And it can help reduce that. So again, it's a VEGF inhibitor or anti-VEGF. And it decreases the swelling, it reduces vision loss and improves vision. That's what we want to hear when we hear we have a treatment or a medicine for something. The very first one was found called by Avastin. Let's see, Lucentis was the first one that was kind of highly researched. And then someone said, well, that medicine's not that different than this medicine, and I'll show you later why that makes a difference. Oh yeah, it's first, you want to know how the anti-VEGF works? Just a small, no, I'm kidding. We're not gonna go through that one. This is what you want to see. It's like, it takes this, remember how we're supposed to have a flat and a dip? This is like a volcano mountain. And then it gets a little better, and a little better, and a little better, and he's almost starting to get their dip back a little bit down there. This is what anti-VEGF does over a series of cycles of treatments. So it gets rid of the blood, it gets rid of the fluid, your vision improves. Slowly, gradually over time. Again, hopefully that shows, you can see some of the thick blood over there. Getting better, improving, like I said. You're even starting to see that dip come back a little bit from that mountain volcano, improving and improving. So that was big for us. That anti-VEGF came out about 15 years ago. So the cost of those injections, we saw the other ones were about $2,000 a pop. The newest one, which is called a VEGF trap, is a little more, $2,300, but it sometimes can go out every 3 months. So that's been kind of nice. These are the people that can maybe go every 12 weeks instead of every 4 weeks. Most of Lucentis, you know, I think when that first came out was like 5,000 a shot. And that's when they said, you know, Lucentis or Macugen, you know, they're all running right around that. But when that first came out, this one's been working really well too, stretching it out, Eylea. But I think it was, well, I don't have Macugen back up there, but Lucentis, Macugen, I think they first came out, was about $5,000 a pop per shot.
When you say they improve over time, what kind of time are you talking?
Yeah, that's the type, what type of time are we considering improving? Generally, I would say over the course of a year, but it just really varies. Some people can get a very quick response. Some people aren't as lucky and they don't respond. So why do we have all these different kinds? Because sometimes they don't respond to this one, but they might respond to that one. And so they do try different ones if they're not responding. Avastin, the one that was approved for colon cancer, $55 a shot. So when the retina specialist prefers getting this, and Macugen or Lucentis were saying, here we have this stuff to treat macular degeneration, it's $5,000 an eye. And someone said, well, we got the stuff for colon cancer and that works the same. It's almost the same stuff. Let's try that. We can get that for $55. So, but that was considered off-label use. I think it might still be considered off-label use, but it's standard of care now, or almost to what we do. But Avastin doesn't work for everybody. So sometimes we try the Eylea, and the Vabysmo is working really well, and you can stretch it out longer. There is one other one that's not, they thought it would stretch out longer, but it's not quite coming out to play the way we hoped. So injections, there's no pain receptors inside the eye. So once we get through the outside of the eye, they I want to say anesthetize you, they freeze it, they disinfect the surface of your eye, they inject it, but there's no pain receptors in the eye. So it sounds terrible getting a shot to the eye. It's not so much the shot, it's the disinfecting of the surface because we don't want to be pushing bacteria and stuff into the eyeball. The shot itself isn't so bad. It's the disinfecting of the eye that's the painful part. And a lot of times afterwards, after that disinfecting, we have to rinse it all out because it'll kind of give you a corneal abrasion if we don't. So your cornea is aggravated because we disinfected your eyeball. The shot itself is not that bad. But there's still side effects. I mean, you get redness and watery eyes and bleeding and pain. So you can get chronic dry eyes. Things can happen. Luckily, not that often. There can be more serious ones with a retinal detachment. Endophthalmitis is one of the worst. That's an actual infection in the eye. And then, like I said, you can always have a reaction. And the newest ones, the dry macular ones, there's a risk of vasculitis and macular, converting to wet. So in summary, yeah, have regular eye exams. That's the biggest thing I'd recommend for you. Eat right, exercise, quit smoking. Like I said before, if it's good for your heart, it's likely good for your eyes, good for your macula. Consider vitamins. If you want, people ask again, grandma has it, I don't want to get it. I might have the gene for it. What should I do? Well, like I said, wear your sunglasses. Eat right, diet, exercise. Usually I tell people, your dark berries are supposed to be better than high antioxidants like blueberries, blackberries. Wear your sunglasses. It's like a misspelling there. And then check the grid. Like I said, if you don't have a grid, look at a calendar. Look at anything that's supposed to be straight. And then let us know if you notice anything. And then there are some new injections for the dry type, but they're not without risk. And they're only work if we do early, but people with early aren't having really problems yet. So we still have to do better at that. And we'll see how that plays out. That's just still very early in it. Oops. And for the wet, yeah, most of us still continue to have regular injections on that. But they're trying to stretch it out 4 times a year, going to see the specialist versus, 12 times a year to run the lacrosse. And right now we don't offer the injections at our clinic for a variety of liability reasons, but unfortunately, yes, everybody has to go to lacrosse for them. Maggie.
So for the wet and the injections, do the injections stop once you've gotten to a certain point, or do you have to keep going?
Yeah. So the questions are, do you get to a certain point where you can stop? Very few people, the lucky ones, can, but most don't. Most have to continue. The best we can do is kind of start stretching you out. But if you stop, a lot of times it comes back. So for most, they cannot. On occasion, someone gets lucky and they can. Or like I said, we might try the different medicines to see if we can at least go longer. But at this point, by far, most return if they don't do that. Good question, though. All right, I think that's it. Now, yeah, any more questions on macular degeneration?
So to clarify, so the wet is more worse than the dry?
That's always a tricky question. Like, is wet worse than the dry? The wet is more detrimental, can take your vision faster, but we have treatments for it, but it's for a lifetime of injections. The dry may not progress. You might stay mild for most of your life. We don't have much other than vitamins, controlling risk factors. Now, maybe some new medicines, but they can cause some risks that we might not want. So, but yeah, which is worse?
Is there some contributing factors that would cause you to have wet versus dry?
Not that we know of yet, other than maybe those genes marking, but right now they haven't said that those genes, they say advanced form, but advanced form could be advanced dry or wet. So I haven't seen that the genes, we have the genes or have a more propensity towards the wet. I don't think they've said that yet. At least that hasn't come to my attention. But, no, good question.
You said dry could go to wet, can wet go to dry? Can it go both directions?
No, not usually. Well, it's usually once it's wet. I will say. I have some people, so it doesn't necessarily go to dry, but we'll say it's inactive. So
Wet is in
the wet can be inactive. For those lucky people that get to stop. So they've had the injections, they got better, it stayed quiet. When I put in like the diagnosis code, I'll say they have. History of wet AMD. But currently inactive, meaning it's not flared up, and so we don't usually go backwards, but we will say it's inactive. We're getting into some semantics on what we use, but I guess you could say that's sort of like going back to the dry. But that's not how we classify it, I guess, but for you, I'd be like, yeah, I guess you could kind of say that. But we describe it differently.
If anybody wants business cards, there's cards on the table over here. If you want to pick up a business card for Dr. McKay or any of his partners at the print.
Yep, we're up there pretty much Monday through Friday, 8 to 5. Yeah, if you have more questions afterwards, you can come up to me. I'll be hanging around for a little while to answer more questions if you have it. And with time, I'll answer any other eye questions. I love eye stuff, so. Anybody have any other eye questions that they want to ask?
Yeah, feel free to stick around here a little bit. It sounds like Dr. McKay will answer any questions you have. I will be posting this video on our website, or technically our YouTube page, which you can find on our website. If you wanted to ever look back at this, and it sounds like also I can get the PowerPoint.
Yep.
And so I'll probably post that in there as well if you wanted to take a closer look or share with anybody you might know. But for now, thank you so much for coming, and can we get a big round of applause?
Thank you for having me.
Yeah, thank you so much, everyone.
Thank you
And for
from
you all,
Viola
the
Library.
little thing we were talking about for the grid looks like that, in case you could see. So thank you for joining us.
Cool.
Like I said,
Thank you from
this will be
Viola.
on our YouTube.
Thanks.
Yeah,